Fine, thanks. So I'll be talking about interpretation of corneal imaging for a refractive patient. And the objective, of course, is to ensure that we do not end up with certain unfortunate incidents like ectasia. No financial interest in any of the devices, equipment, techniques mentioned. So corneal topography essentially is the essential component of refractive screening now. And the objective is to detect corneas with ectatic disorders, established ones, and also which are easy to detect, and also detect corneas which are at risk for ectasia, which is the more difficult part. And therein the need for some newer devices. So topographic systems can be Placido ring system based, like the reflective ones, which we've been using traditionally for many, many years since our residency days, and the elevation based, which are the scanning slit system and the Scheimpflug camera based. So the Scheimpflug elevation topography is the standard of care now for refractive screening. The Placido alone would not work well. There are combination devices which would help. So let's look at color coding. Now the maps are presented as a color code. They're color coded maps, and Placido based show the corneal curvature is measured and is shown as colored maps, and in elevation based the elevation is shown as colored maps. Now what is the need for this? If you look at this picture here, you'll see some Placido images. What does it convey to us? Nothing much, except that there's some rings. But when you process the image, when the device processes the image, the topographer, and presents it as color data, this is how it becomes, and you are able to interpret. So for curvature maps, surface curvature is measured, and the warmer colors show steeper curvatures or higher powers, as we call them, which are the reds and the oranges. Greens are more of the usual curvatures and represent normal corneas, and the cooler colors like the blues, they show relatively lower powers or flatter curvatures, as we call them. But please note that standard color scales, actual power values, the intervals, and the colors actually used differ from machine to machine and should be standardized. You cannot just compare one printout from one to the other. For relative elevation, there's a reference surface which is taken. I'll talk about it a little later. And anything above that is called anterior. Anything posterior than that is shown as a cooler color like blue color. And green is the surface for the reference surface, and anything higher than that or the anterior to that is shown as a warmer color like the reds and oranges. So these elevation systems provide much more information than topography, and we have, as I said, the scanning slit based or the OBSCAN, and the Scheimpflug camera based like the Pentacam, Sirius, Galilei, and there are various other refinements also in each of these. So now, why curvature and why not just curvature, which was tradition, and elevation now? So if you look at this sphere, and in this there's a segment called CD, which would have been here but has been depressed, and it's at a different elevation. It's a lower elevation. If you look at it, the curvature of A and B is the same in C and D. So if you're limiting ourselves to curvature maps, we would say that the curvature is the same, but the actual fact is that it's at a lower level. So elevation maps give us some more information too. Now, elevation maps seen by itself would not mean much. Now, this is a Google image of the Himalayas, which we know are more than 8 kilometers in height from the sea level. So if you just look at it, it does not convey much. It's a flattish thing. Okay, you see some snow-capped peaks over here. But when you take it compared to a reference surface, which is a sea level, you realize, oh, it's a pretty high one. And if you were to show a bigger area, the sea would have been covered. So reference surfaces are close-fitting surfaces, and we try to get a best fit surface. So for instance, if this yellow line is the actual objective, and then we get a sphere, a surface which is closest fitting to it, and then we compare. So anything higher than this close fit sphere, best fit sphere, would be shown as a warmer color. Lower ones would be shown as cooler colors. Now this thing would make a little more sense, which I talked about. A reference surface which is green, and anything higher or anterior would be warmer. Lower or posterior would be in the blue, cooler colors. So these are the various, so I'll be focusing on Scheimpflug topography, which I feel is the standard of care for refractive surgeries. And there are various devices, primarily the pioneer and so-called gold standard now is the Pentacam, but the other device is also very good. So a Pentacam has a rotating Scheimpflug camera, which provides sharp and crisp images of the anterior segment and provides a lot more data than traditional topographers, and therefore is known as a tomograph. It provides data from anterior corneal surface to the posterior capsule of the lens. And it is based on the Scheimpflug rule. What happens basically is that in conventional cameras, the object plane, that is the film plane, the lens plane, and the subject plane, that is the subject, they are all parallel to each other. Whereas in Scheimpflug cameras, they can be oriented at an angle to each other, and they intersect at a point called the Scheimpflug intersection or line. So this is the Scheimpflug camera. If you remember these older cameras, this is the lens plane, the film plane, and the subject plane, and they can be need not be aligned. And the advantage is that images along the optical axis of the eyes can be assessed too, and which was a big disadvantage with the Placido-based topographers. So these systems give us precise measurement of the central cornea, and correction of eye movements is there. There's very easy fixation of target for the patients, and the acquisition time is extremely short. In 2 seconds, you get a lot of data. So they do help us analyze anterior chamber. The pachymetry maps are given, topography maps, both anterior and posterior are given. The elevation maps are given for both the anterior and posterior surface. It helps us analyze the cataract. The Bellin-Ambrosio enhanced ectasia display is given, which is very important. The holiday report, which when you use for post-refractive surgery, cataract surgeries. The tomography is there, and the corneal wavefront, all less than in 2 seconds. So how is the data presented? There are various display formats. The commonest one being the 4-map refractive, where you have the front surface, the back surface, the corneal thickness, and the tangential or the curvature map. And here you have the identification data. This is the corneal front surface keratometry values and the astigmatism and the axis at which it is, the corneal back surface. Then you come to the pachymetry, which is there, the center, the thinnest, and the local point, and the anterior chamber depth. So this is another display where you get the keratoconus indices are given, and the pachymetric display is also given, where this helps us in basically gives us pachymetry across the surface of the cornea, and you can see how it progresses, how the pachymetry changes across the surface of the cornea, and it's a good screening tool for LASIK patients. So coming specifically to the screening parameters, we check the best size of the best fit sphere, because this influences the borderline numbers. If it's an 8 mm size best fit sphere, the numbers would be different compared to the 9 mm one. And then we look at the anti-elevation map, the central and the paracentral areas. In the 9 mm zone best fit map sphere, the anti-elevation, the highest point should not be more than 15 microns, because then it is indicative of keratoconus. Less than 12 is normal, and anything between 12 to 15 is suspicious. In the posterior map, there are numbers are similar, about 5 microns higher. For instance, for keratoconus indication, it would be 20 microns or more in the posterior map. For 8 mm zone of best fit sphere, as I said, it's different. And on the anterior map, anything more than 8 microns is indicative of keratoconus, and the posterior, anything more than 16 is indicative of keratoconus. So if you look at this map, you see this is a posterior surface. Let's just look at the posterior surface to save time. There's about +2 over here, and as I said, +20, and in the best fit sphere, it's a 8 mm. So anything more than 8 would be indicative. So this is a normal map. And here again, 8 mm, but the values here are 74 and 59. So this is much more than 12. So then it is indicative of keratoconus. There could be a keratoconus. So you need to be cautious. But when you look further, you see the keratoconus indices all are highlighted over here. They're all positive. So coming to the other important aspect, the Bellin-Ambrosio enhanced ectasia. Now, what does it do? As usual, it will depict the whole sphere. The best fit sphere is for the whole sphere, and then enhanced by ignoring the central 4 mm zone around the thinnest spot. And the advantage is it gives us a pronounced cone and a traffic-like evaluation. So if this were the keratoconus cornea, this is the central bulge. This is the thinnest area. You ignore the 4 mm around it, and this is the best fit sphere for this. If you ignore it, you'll get a best fit sphere like this. And the difference is mapped, and that gives us the enhancement and lets us know that, okay, there's something happening. In contrast, in a normal cornea, this is the best fit sphere. Even if you remove the central 4 mm on the thinnest spot, the map would remain essentially the same, and there would be no difference. So this is what happens. In the best fit sphere, when it is compared, this is what you see here. And when you see the difference in the map, this is the normal standard best fit, this is the enhanced best fit, and the difference here shows a higher, shows the red light, shows this difference here. And this gives a traffic-like kind of signal. Is red, green, and yellow. Green is okay if the central entire thing is green is okay, and red shows that it's abnormal, and yellow you should be suspicious. So this is another map to show Bellin-Ambrosio enhanced display. This is Bellin-Ambrosio display 2, where the D value, anything more than 1.8 or 2 is considered suspicious. So corneal thickness spatial profile essentially shows how the cornea is thinning out towards the periphery, and any dipping down of this axis in these graphs, cutting across, they should all stay between the dotted lines. Any cutting across is doubtful. The last important point that I want to discuss is the Ambrosio relational thickness, ART map. Basically, it is the relation between the ART value and the progression, pachymetry progression index, which is all given in the map. And any cutoff value, it is shown over here in this area. It's 456 here. Anything less than 400, we should avoid refractive surgery. That's the recommendation. And anything more than 339 and less than 339 is indicative of keratoconus, and 391 is susceptibility for ectasia. So here you see it's a normal ART value. Everything is looking normal over here. These Bellin and Bruzo displays, 1 is good, 2 is good, the lines are normal, this graphs are normal, CTSP profile is normal, the art max is good. And in contrast, in this map, you see the values here, it's plus 22, it's a little more for a 9mm, it should not be more than 20, you become suspicious. You look at the Bellin and Bruzo display, it's showing some abnormality here. The Bellin and Bruzo display 2 is also more than 1.8, it's a little suspicious. The graphs are slightly dipping down, but not cutting across. But the art max value is 377. As I said, anything under 400, you should be suspicious, and at 392, you should be suspicious and avoid a refractive surgery in the first instance. In this patient, I would like to observe for some more time. Here also similar features. The other eye of the same patient, the art max is normal, so is suspicious. Sorry, 362. And similarly in this patient, you see here actually you could observe the art max is 400. And this is, if you notice, a very high astigmatism, and that could probably account for it. So we still haven't got over high astigmatism because sometimes they mimic these changes in the corneas. I think this is a good time to conclude. Corneal topography is an important tool today and requires some effort to understand initially. And it is important for refractive surgery screening and detecting ectatic corneal disorders. Neurotopography systems perform multiple functions and may provide more value for money. But remember, there's no ideal and perfect system available yet, and we still have to look for it and use a clinical judgment. Thank you for a patient hearing. There's some scenarios, but I think I'll skip it in the interest of time.